Hello, my name is Michael Hartung. I am an abdominal radiologist at the University of Wisconsin and editor at Radiopedia, and I will be presenting an introduction to abdominal CT. As you are probably aware, CT is the workhorse of abdominal imaging and the highest yield go-to exam for acute abdominal pain and cancer imaging. But before we jump right into talking about CT, let's take a few moments and try and understand the complementary role that CT plays with X-ray, ultrasound, and MRI. When a patient needs imaging and you are trying to decide the best place to send them, it is helpful to consider the CT donut. Specifically, you need to step back and ask yourself what results you're expecting from an exam and if that result will be sufficient to guide treatment or rule out disease, or if the patient will likely require advanced imaging regardless of the outcome of the study. This is often particularly the case for X-ray in the acute setting, and that is because a positive exam is unlikely to give you a specific diagnosis that can guide treatment, and a negative exam is unlikely to be reassuring enough to stop the workup. And there you have your donut, both positive and negative results leading to a CT. There may be some indications, such as stool burden, foreign body or not, and tube placement that X-ray does well, but more often than not, you'll be looking at a donut. Ultrasound, on the other hand, can be an appropriate first study for a few specific situations. Specifically, for right upper quadrant pain, pelvic pain related to the uterus or ovaries, and the appendix for select thin or younger patients. CT can confidently diagnose acute cholecystitis, but ultrasound is better for sludge and stones and does not carry any radiation dose. You might try your luck at identifying the appendix with ultrasound for younger and thin patients, and the success of this technique relies greatly on operator expertise as well. Ultrasound is the best exam to quickly evaluate the uterus and ovaries and is frequently used to evaluate for ovarian torsion, pelvic inflammatory disease, or complications related to early pregnancy. Now, how might we consider the relationship between MRI and CT? When I recommend an MRI, I like to think of a specific question or imaging puzzle that I'm hoping to solve, and that is because each exam is tailored to best evaluate different anatomic regions in pathology. There's no single phase workhorse for MRI like we have in CT. You need to come to the table with a specific question. MRI is great for helping to characterize unknown liver lesions or for MRCP to look for stones, and it is also commonly used to perform detailed local cancer screening or staging like seen in the prostate MRI here. MRI is less commonly used in the emergency setting but does have utility in pregnant patients to evaluate for appendicitis, small bowel obstruction, or other pathology after clinical evaluation and usually ultrasound. Now that we've considered the complementary roles that X-ray, ultrasound, and MRI play together, we can review the common indications for CT of the abdomen and pelvis in both acute abdominal imaging and cancer imaging. For acute abdomen, this list covers many of the common reasons CT is ordered in the ED and is probably familiar to you. For cancer imaging, CT remains the workhorse for staging and follow-up, but is frequently accompanied by PET-CT to evaluate for tumor metabolic activity, MRI for local staging and surgical planning or problem solving, and bone scans which provide greater sensitivity for metastases than CT alone. Now we'll take some time to focus on the key elements of abdominal CT, including contrast type and exams based on the indication for the study. Speaking of workhorse, the vast majority of time you'll want to stick with CT of the abdomen and pelvis with oral and IV contrast in the portal venous phase only. This single study provides the best balance of solid organ, bowel, and vascular enhancement for you to be able to answer most clinical questions. The oral contrast is bright within the bowel lumen and can aid in confidently identifying a variety of pathologies, although it is usually not necessary to make a diagnosis. Oral contrast is a bit of a controversy and the use depends on the institution, as indeed it does result in some increased waiting time in the ER as you wait for the patient to drink, and many patients feel that they are too sick to drink the oral contrast. This is an excellent best bang for your buck list of when to consider using oral contrast, but perhaps the best application is for thin patients where that positive or bright oral contrast really helps you evaluate intra-abdominal structures that are otherwise difficult to distinguish from each other. Let's now discuss intravenous or IV contrast. When you do a CT without IV contrast, you get the contours of the major structures, but very little information about what is going on inside of them. With IV contrast on board, you can assess the enhancement, vessels, and have much greater confidence for evaluation of underlying lesions of the solid organs. The two medical barriers to getting IV contrast are renal failure or severe allergies such as anaphylaxis, but the most common reason why a patient doesn't get IV contrast for CT in the emergency setting is the renal stone or flank pain study, which is ordered in preference of a typical CT with IV contrast when there's a high suspicion of renal stones and it has the added benefit of carrying a lower radiation dose than a standard CT. Here with this example flank pain study, you can confidently assess for hydronephrosis and renal stones. Shown at the upper image, there's hydronephrosis of the right kidney with a distal stone in the lower image at the ureterovesicular junction. Here, IV contrast is not necessary to make the diagnosis. But that's not to say that non-contrast or flank pain CTs cannot address many of the concerns for acute abdominal pain. In fact, I would encourage any reader to carefully review all the structures in the same way that you would for a contrast CT. Here are example diagnoses that I have come across on flank pain studies where IV contrast would have increased the confidence but was not necessary to make the diagnosis and appropriately advanced patient care. A big area of confusion and uncertainty among radiology trainees and other clinicians alike is contrast bolus timing, specifically the different phases of contrast and what information they add to the study. The most common study, the CT in the portal venous phase, has images obtained around 70 to 80 seconds after the injection of contrast, and that is the workhorse of CT because it provides the best balance of solid organ, bowel, and vascular enhancement for general imaging. Arterial phase can range from about 20 to 35 seconds, depending on if you just want to evaluate the vessels, which is known as early arterial phase, or if you want to see if anything in the solid organs or bowel has abnormal arterial enhancement, such as hypervascular masses or metastases, which is known as the late arterial phase. As you can see here, the aorta and vessels really light up and can be confidently assessed, and we are in the relatively early arterial phase because there's little enhancement of the liver or spleen. For cancer imaging, the arterial phase has an important role in staging, screening, and assessing for metastases. This study was done in both the arterial and portal venous phase and allows the reader to confidently diagnose hepatocellular carcinoma based on the avid arterial enhancement early and washout on the later portal venous phase compared to the background liver parenchyma. Arterial phase is helpful for other cancers like renal and neuroendocrine tumors, as they can have hypervascular metastases that blend in and are not well seen on the portal venous phase alone. Many hepatocellular carcinoma protocols also include a delayed phase, which can further increase confidence in washout, which is an essential characteristic for making the diagnosis of hepatocellular carcinoma. Such delayed phases are usually done at the 2 to 3 minute mark, but in practice, HCC can usually be diagnosed with arterial and portal venous phases alone. Let's now discuss the last phase, the excretory phase, and it's way out there, usually at 8 minutes or greater. It is added when you want contrast to opacify the urine so you could see inside of the collecting systems, ureters, and urinary bladder. It is the sequence that defines the urogram and is used for screening and characterizing urothelial carcinoma. While the portal venous phase might allow you to see some filling defects in the collecting system, like in this example, they are often quite subtle. The differences between soft tissue filling defects and contrast-enhanced urine in the excretory phase allow superior detection and characterization of such lesions. To summarize, you'll see multiple phases when doing cancer imaging for hepatocellular carcinoma, pancreas adenocarcinoma, neuroendocrine tumors, renal cell carcinoma, and urothelial tumors. But what about in the emergency setting? Does multiphasic imaging play a role here? And the answer is yes. This protocol is a GI bleeding protocol performed in a patient who presented with rectal bleeding. The essential sequences here are a non-contrast CT, which allows you to dismiss any dense material in the GI tract after contrast is given, arterial and portal venous phases, which are done to provide 2 time points after giving contrast that allow you to see contrast entering the lumen and dispersing over time. Here in this example, contrast enters the transverse colon during arterial phase and disperses in the portal venous phase, confirming that is the location of active bleeding, which will help guide embolization therapy. Mesenteric ischemia is another common indication for multiphasic imaging and has late arterial and portal venous components to assess for vascular patency and bowel enhancement. The arterial phase is needed to evaluate the superior mesenteric artery and its distal branches, which I've emphasized using a special reformatted image here, as well as early enhancement of the bowel. The portal venous phase is needed to evaluate the mesenteric veins, delayed bowel enhancement, and also to provide complete anatomic imaging, which can check for a potential alternative cause of abdominal pain, as often there's something besides ischemia that's causing the patient's pain. These patients also do not want to get oral contrast, not only because they're usually pretty sick and unable to drink, but because dense oral contrast can sometimes make it difficult to assess for subtle abnormalities in bowel wall enhancement. So this list covers the major reasons why you'll want to add additional phases in the ER, and as I mentioned, these patients do not need to receive oral contrast. So far, we've covered IV and oral contrast and different exam types, and now let's turn our attention to search pattern and radiology reporting. The basis of both imaging review and reporting is that of a search pattern. That is, reading the study the same way every time, systematically looking at all important structures. This example, structured report in the middle, highlights how abdominal CTs can be reported, starting with the lower chest, moving on to the abdominal organs, bowel, vessels, nodes, reproductive organs, and musculoskeletal structures and body wall. Let's take some time to go through that key anatomy and search pattern so you can begin reviewing images in the same way yourself. When you first open a study, you'll often start with the axial images in a soft tissue window. Most radiologists like to take a quick scroll through the study so they get a sense of how complex the study might be and perhaps quickly identify an abnormality accounting for the reason of the study. After that, you'll want to pretty quickly settle into your normal search pattern to avoid any sort of satisfaction of search, which refers to the concept of a radiologist identifying one abnormality but potentially missing other more significant ones. Starting with the lower chest, we can switch to a lung window using a keyboard shortcut and evaluate the lung basis, which has a few strandy opacities indicating atelectasis, but otherwise looks okay. After that, we can switch back to a soft tissue window, look at the heart, and look for any pleural effusion, and then move on to the solid organs. When you're evaluating the liver, you'll want to think of a bit of a checklist, first starting with the liver parenchyma to look for any abnormal masses. Then, look at the gallbladder, intrahepatic ducts, and biliary tree, following the common bile duct down through the pancreas head, and finally the liver vasculature with the portal vein, intrahepatic branches, and also the hepatic vein and its confluence near the inferior cavoatrial junction heading towards the right atrium. After you evaluate the liver, it's time to move on to the pancreas. And the key pancreatic anatomy is the lowermost portion, which is called the uncinate process, the pancreas head, where you often see a little dot of the common bile duct, the pancreas neck as it crosses over the superior mesenteric vein, body, and tail heading towards the spleen. Evaluating the spleen, we're looking at the overall enhancement and perfusion of the spleen and potentially for any other lesions. The adrenal glands sit on top of the kidneys with the left and right adrenal with a characteristic inverted Y shape. Moving on and looking at the kidneys, we're looking for any abnormalities of enhancement, mass, or collecting system dilation. After evaluating the kidneys, I follow the ureters down, which can be hard to see in some patients, but I do my best attempt at following the ureters all the way down to the urinary bladder. Here's the distal ureter and the uretrovesicular junction to the urinary bladder, and then I'll follow that left ureter back up to the left kidney. After evaluating the genitourinary system, it's time to look at the gastrointestinal tract. And while we're down here, I like to run the lower GI tract starting with the end, identifying the anal canal and working my way backwards to the rectum, the sigmoid colon, descending colon, transverse colon, hepatic flexure, ascending colon, and cecum. And as you find the cecum, you'll notice distal small bowel, accounting for the terminal ileum, the ileocecal valve, which is a little hard to see here, and if you scroll carefully and look, you'll usually find the appendix at this point. Here the appendix has a small amount of air within the lumen and is normal. You can follow the terminal and distal ileum back a little while to ensure there's no abnormal enhancement or thickening, but after that, it's most efficient to simply look at the small bowel as a quadrant, here accounting for the ileum in the right lower quadrant, the mid small bowel, and in the left upper abdomen, the jejunum with its characteristic feathery fold pattern. And we'll take a second look at the small bowel on the coronal images as well. Running the upper GI tract, I start with the distal esophagus, gastroesophageal junction, stomach, pylorus, duodenal bulb, and second portion of the duodenum, heading down into the third portion, which crosses midline, to the ligament of Treitz and the proximal jejunum. After evaluating the gastrointestinal tract, it's time to look at the vessels in more detail. We already looked at the portal vein, but here we can follow the portal vein to the portal splenic confluence, to the splenic vein, and the superior mesenteric vein. The key arterial vasculature, the distal thoracic aorta, its first branch, the celiac artery, to the common hepatic and splenic arteries, the second branch, the superior mesenteric artery, renal arteries, and here we're noticing the renal veins to the IVC, and as we head inferiorly, the inferior mesenteric artery, aortic bifurcation to common iliacs, internal and external iliac arteries, into the femorals. After evaluating the arteries, it's time to look at the lymph nodes. The key lymph node territories include the gastrohepatic ligament, which only has a few small lymph nodes and is particularly important when staging esophageal or gastric cancer. Here, at the origin of the celiac artery, are these linear, sort of ill-defined structures, which are the celiac ganglia. Between the portal vein and IVC are portocaval lymph nodes and portohepatus lymph nodes, and heading inferiorly, small lymph nodes surrounding the abdominal aorta are commonly referred to as retroperitoneal or periaortic lymph nodes. And in the pelvis, you follow the vascular spread of the iliac arteries to look for corresponding lymph nodes into the inguinal region to account for the inguinal lymph nodes. Finally, in this male patient, we can look at reproductive organs, although CT is generally quite limited for this evaluation, where we see the prostate and seminal vesicles, and we can look at the patient's body wall and musculoskeletal structures on standard windows for any asymmetry or abnormality, and then switching to a bone window, we can scroll through slowly and look at the bones for any areas of cortical abnormality. While it is good to be in the habit of looking at the spine on axial images, most people find its evaluation on sagittal to be much more straightforward, which I'll show you shortly. Here in the pelvis, we can look at the sacroiliac joints, iliac bones, hip joints, and have a good evaluation of the pubic rings and proximal femora. As I mentioned, sagittal reformats are great for looking at the spine as it lays out the long axis of the spine, and we're able to see all of the vertebral bodies, their alignment, and the posterior elements. The coronal images are helpful for looking at the pelvis, where you can evaluate for any sort of asymmetry of the proximal hip joints, particularly in the setting of trauma, the sacroiliac joints, and portions of the spine as well. It's also worthwhile to review the key anatomy on the coronal images in soft tissue windows, as this view is more intuitive for most non-radiologists because it represents how you look at the patient. Here we can see the liver parenchyma, the portal vein heading in to the hepatic hilum, gallbladder, cystic duct, common bile duct heading to the pancreas head and towards the ampulla. And here we have the pancreas head, body with a portion of the pancreas duct, pancreas tail, spleen, adrenal glands, and kidneys. And the coronal view is particularly helpful for looking at any asymmetry or abnormal enhancement between the two kidneys. And it can also be a helpful safeguard against overlooking a mass that might be easy to scroll by on axial, but really does stick out well on the coronal. So really important to look at the kidneys on coronal views. And when we're evaluating the gastrointestinal tract, what you'll notice is we get to see much longer segments with larger clusters of the small bowel. Here we can appreciate the difference of the feathery fold pattern between the jejunum and the ileum, as well as the characteristic pattern of haustra within the large bowel. Running that upper gastrointestinal tract, here's the distal esophagus, gastroesophageal junction, gastric body, antrum, and then that sweep. Second portion of the duodenum down, third portion crossing midline, ligament of Treitz, into the proximal jejunum. I hope you found this review of key abdominal CT anatomy and search pattern helpful, and encourage you to spend some time reviewing the annotated and non-annotated images linked to this lecture to further expand your understanding of abdominal CT anatomy. Thank you for your attention, and I hope you've enjoyed this review of abdominal CT.